Yes. Okay. This is the classical demonstration, the classical scheme about T2 and non-T2 asthma. And you have the epithelium, as I told you yesterday. You have the allergic asthma, the eosinophilic asthma, and the non-T2 asthma. Here, if you have in the allergic part, you have the epithelium, you have the alarmin, the TSLP, IL-33, IL-25, the dendritic cells. The dendritic cells stimulate the naive T cells, and the naive T cells, if they are T2, they produce IL-13, IL-4, and they stimulate the B cells, which produce Ig, and the Ig, they go on the mast cells. And it's the mast cells, they produce the histamine release and different factors, and it's the immediate asthmatic reaction. You have also, and this is so it could be the allergen, the trigger, the fungi, but I told you also that allergen could stimulate the innate receptor, because on the epithelium, you have also you have the toll-like receptor. Toll-like receptor are the receptor for the innate immunity. This is the first. Then you have the eosinophilic, and it also, you could have stimulation from allergen, fungi also, but you have also bacteria, virus, smoke, and that's created that stimulate the alarmin, TSLP of IL-33, stimulate the T cells from the innate immunity. The T cells of the ILC2, they produce IL-5, which stimulate the eosinophils, and the eosinophils, they stimulate the precursor of the IL-5, and you have the production of the IL-5. The IL-5, they go in the blood, but also they go in the lung. And then you have the non-T2, again, stimulation of the TSLP, and the TSLP, there is a direct, it could have a direct action on the mast cells and stimulate the fibroblast and the collagen. So you can see immediately what will be the target. At the beginning, the target will be on the Ig, the anti-Ig. Then the target will be against the IL-5. Also, there was the IL-13 after, IL-13, IL-4, it's dupilumab, IL-5 is Nucala, or it's dupilumab, no, not baricitinib, sorry. And then also now you have the anti-TSLP, because considering that the TSLP could have an effect on the allergic, eosinophilic, and non-T2 asthma. So I'm not going to show to you all the study, because Nucala is available. I'm sure you have already seen all the studies about biotherapy. I wanted just to underline different points when you're using biotherapy. Before biotherapy, you need to manage the comorbidity and the environmental exposure. You know, you have 9 questions to ask before to see if it is a non-resistant asthma. So you need to check the adherence, the technique of taking inhaled treatment, you increase the therapeutic burden, you increase the high dose of inhaled corticosteroid, you had anticholinergic, and also you phenotype your patient. Is it an allergic asthma? Is it an allergic asthma and eosinophilic asthma? Is it a non-T2 asthmatic patient? You need also, it's very important to be very clear about the objective that you want to obtain with your biotherapy. Because biotherapy is very expensive, so you need to know what you really want to do with that. And you have to, if it is about reduction of severe exacerbation rates, corticosteroid sparing, for example, the patient has diabetes, is obese, and is always taking oral corticosteroid, and he have all the complication, hypertension, and whatever, diabetes. So, and then also for children, reduction of work or school absenteeism, and the quality of life and asthma control. So things must be very clear at the beginning with the patients. you say, okay, what do you want? What are your expectations? So decrease of severe exacerbation. I will be very fast because you know that this is the innovate with omalizumab. You have a decrease by 25% of significant exacerbation. With severe exacerbation, you have a decrease by 50%, and you have a reduction of the emergency room also by 40%. If you look at IL-5 mepolizumab in the Nucala, and the results were similar. You know, in fact, to be short, because I know the time is running, exacerbation also with mepolizumab, you have a difference. Look at that. This is the severe exacerbation. This is the difference between the placebo and the treatment. It's mepolizumab intravenously. It's not like that subcutaneous. And also, if you look at the FEV1, you have an effect also with mepolizumab. So, Xoller, Nucala, yeah, you obtain that. And this is the result that you obtain. Look at the difference. It's by 53. You have the mean rate of clinical significant exacerbation, a decrease of 53 using mepolizumab. The mean of severe exacerbation, 71%. This is the pivotal study. And look at also, it's interesting, it's the severe exacerbation rate. It's 1.7, and you have a decrease by 50%. Remember the figures that I showed you before. One point, I think it's very interesting. It's eosinophilia and atopy. 75% of the allergic patients, they develop eosinophilia. So what to do with this patient? Because in this patient, you can use omalizumab, or you can use also an anti-IL-5. And this is the study with mepolizumab. And look at that. This is the annual exacerbation. Here you have placebo, mepolizumab, and the patient, the annual exacerbation rate by prior omalizumab used in two studies. It's a post-hoc analysis. So this patient didn't work with omalizumab, and then they decided to put them under mepolizumab. They have placebo or mepolizumab. They have omalizumab prior. So we increase, you have a decreased rate of exacerbation. So in this patient, you obtain, if it doesn't work with omalizumab, you could increase the efficacy of for the patient by using an anti-IL-5, because it's the same with maralizumab. You decrease the rate with the placebo, the rate of severe exacerbation was 2.3, and it decreased to 1. For those who did not have omalizumab before, using mepolizumab also decreased significantly, almost by half, again, the same, the rate of severe exacerbation. So you begin with omalizumab, it doesn't work. You can go to an anti-IL-5. You can obtain, you have in 50%, you have 50% chance to decrease the severe exacerbation. But again, this patient is very interesting, and I'm very sad because this morning I woke early to prepare this slide. But these allergic patients who produce eosinophil, who produce activated eosinophils, I think they are the target for biotherapy. Maralizumab, it's an inhibition of the receptor of the IL-5. And here is the one of the pivotal study, more than 700 patients, the GINA 4 to 5, medium dose of inhaled corticosteroid, and they look at the severe exacerbation frequency, and you can see that we are in the same we have decreased by 28%, 38%. This is the annual rate for exacerbation. And the annual exacerbation rate, well, this is for the patient with, yes, with more than, with an eosinophilic asthma. So you have a decrease by 30% of 28%, and those who are less than 30, 300 eosinophils, a decrease by 36% and 40%. So it's very similar. The difference with baralizumab, it's every 2 months as compared to Nucala, which is every month. Dupilumab, it's anti-IL-5, anti-IL-13. And this is just, I summarize all the results in patient having dupilumab. Yeah. Oh, yes, the 2 doses of the dupilumab, 200 milligram and 300 milligram. And you can see that when the patient has eosinophils more than 300, it is more efficient in the 2 groups, 200 every 2 weeks or 300 every 2 weeks. So clearly, the patient with eosinophils, the response to biotherapy, omalizumab, the anti-IL-5 or dupilumab is better. It's clearly. And here are the results obtained with the FEV1, the effect on FEV1. My feeling that dupilumab is a little bit more efficient than the other for the FEV1, not for the exacerbation rates, but for in the lung function. I'm really in trouble. Yeah, the phase 3 for tezepelumab. Yes, I just show you that you have an effectiveness, the same effectiveness for in patient with low T2 markers and a greater efficacy if T2 mark and if T2 mark, but TSLP remains target for T2 inflammation, and that's also tezepelumab. You obtain exactly the same results. The corticosparing effects. This, with all the 4, you have a corticosteroid sparing effect. Usually, you decrease by half the oral corticosteroid, and this is all the effect here. For example, in France, you have 40% that completely win off of their corticosteroid therapy with the 4, and not with tezepelumab. Tezepelumab, they failed. They did not obtain corticosteroid sparing effect. Now, in non-T2 asthma, I just show you this. We published that very recently in Journal of Asthma. Because at the beginning, omalizumab, omalizumab was used for allergic asthma, but with severe non-allergic asthma during the beginning of the 2000s, we used omalizumab with non-atopic asthma, and we published this series. People here, you have the non-atopic patients and the atopic. And you can see that this is the rate of exacerbation. And you get the annual rate of exacerbation, and the result was not, there was no significant difference. There was a significant difference in the diminution for each group, but no difference between non-atopic and atopic asthmatic patients. So omalizumab works on non-atopic asthmatic patients. There is also a paper from the Spanish Register of Asthmatic Patients, and they found the same, no significant difference between the 2 groups, atopic versus non-atopic, in reduction of exacerbation and improvement of control asthma and quality of life. Long-term effect, because I think that's a real issue. How long do we are going to treat the patients? The first study was with omalizumab. It was export. So Xolair for 6 years, 2 randomized double-blind studies, either stop Xolair and placebo, and either pursue Xolair. And if you look at that, there is an effect when you stop the treatment and the control, the patient in which there are significantly more patients without exacerbation versus those placebo versus Xolair, 68% without exacerbation with Xolair, in contrast with those with placebo when they stopped after 1 year. And those who have more exacerbation after stopping Xolair were those who have an increased total IgE and an FeNO an increased FeNO. The same with mepolizumab, the COMET study. You have also a double-blind randomized study and continuation of MEPO 144 versus cessation of MEPO 151, 1 year of monitoring, and those there is a longer effect. Those who stopped who after cessation, after 6 weeks after the last dose, 59% without MEPO versus 46 with an adverse effect. And the time of first asthma exacerbation, there was a difference, a significant difference. It was the odds ratio was 1:7. And so the same with maralizumab and the same with dupilumab. So there is a long-term effect, but I wanted to show you this. All study is published by NOP, and they use omalizumab for 7 years, and they stopped. The patient were allergic to mite or allergic to cat. And then 3 years after, you look at the number of patients, it's a very small group, 18. You have 12 out of 18 improved their asthma 3 years after stopping. 3 years after stopping, you have 4 out of the 18 still were unchanged, and you have 6 were worse. So that means that at least 2/3 of the patient, 3 years after stopping the omalizumab, still they were very well. And I have this experience also. I have some patients, I stop omalizumab now in 2010, and 12 years after, still they are very well. They are just using beta-2 agonists, short-acting beta-2 agonists. So I think there are, in some patients, there is an effect. The question is now, there is a publication, a recent publication from Belgian people. They just treated the patients for 1 year, and then they stop, and they look at the effects, and they demonstrate that there is a significant effect. There is a significant decrease of severe asthma, more than 30%. So it's the idea, because it's very expensive, and for the patient, what to do. And I think now we are moving gradually. At first, we were 5 years, 7 years, then gradually we're decreasing the time necessary for using biotherapy, just to obtain at least a significant reduction for 1/3 of the patient. If after 1 year they feel great for 2 or 3 years, that's very good, because now we can carry on with another biotherapy. I don't know if I'm clear. Well, yes, this is the adverse effect. It's not. The last stuff. It's about biotherapy and polyposis. I like very much this study. It's from it's a Belgian study from Ghent. It's Bachert study, and I think you are doing exactly the same in Colombia, phenotyping people with polyposis, nasal polyposis. And you can see this is all the phenotype. This is all these patients, they are IL-5 negative. That means when you perform a labeling, immunostaining of the cells of the biopsy in the nose, in the polyps, they are IL-5 negative. And here they are IL-5 positive. So more. And also you can see that for 5, 6, 7, they produce IL-5, but also you have a staining for Ig and from ECP. ECP is a marker of activation of eosinophils. Here you have the MPO and you have the interferon gamma. Okay, this is all the different phenotype. And also in this subgroup 9 and 10, they are positive for Staphylococcus aureus. Bachert is very, very interesting about the sensitization to Staphylococcus aureus, specific Ig in the nose. And he said that it's a subgroup of severity for polyposis. Here you have the percentage of chronic sinusitis without polyps. So here you have these phenotypes, IL-5 negative, they are less polyps and they have less asthma. And these phenotypes, Staphylococcus aureus, IL-5, ECP, more polyps and more asthma. So clearly there is a relation between sensitization maybe to Staphylococcus aureus, so atopy, eosinophils, and activated eosinophils. Again, we are around all this problem, and we have exactly the same for desensitization, and we have the same for biotherapy. So with omalizumab in the nasal polyps, it works. They improve the nasal, and you have they increase. You have different study, polyp 1 and polyp 2, and you have this is aggravation, this is improvement. So using this is with placebo, and this is also with the omalizumab, and you have an improve and a significant improve of the nasal polyps. Improve the endoscopic, the clinical, and the patient-reported outcomes. And you have also the polyp score for the congestion score and for the quality of life. For mepolizumab, it's exactly the same. If you look at that, you have the percentage of patient. This is an interesting data, because these patients, it's the need of surgery, and using mepolizumab, you can decrease the need of surgery using mepolizumab as compared to placebo. The adjust nasal score, the VI score, also you have an improvement using the mepolizumab, and also you have the nasal polyps, you have a decrease using mepolizumab, you have a decrease of the score, the nasal polyp score. And for the secondary criteria, also you have for the rhinorrhea, you have a significant improvement for in the throat, the mucus in the throat, and the nasal blockage, and also in the smell. I think it's very important in a study, because you have a global score, but if each part of the global score is also significant, it's a good indication about efficacy of the treatment. And then dupilumab, and I wanted just to show you that, because to my point of view, dupilumab is the best as compared to the others. It's clearly about the nasal polyps. We had better results, and this is the publication of Bachert in Lancet. And they look at these results, and then they stop the treatment, and you have an increase of the nasal polyp score, and also you have also the sign in the decrease of in the two study in sinus 24 and sinus 52. So it's 1 year. And the congestion is exactly the same. You have the decrease and then an increase. And also you have the cumulative rate of the time to first systemic corticosteroid using use on nasal polyp surgery during the treatment. And here again, you have an increase. You look at the placebo, and using dupilumab, you don't have an increase. So the choice of biotherapy is you have to phenotype the asthma and nasal polyps, at least perform a skin test, FeNO if you can, or perform induced sputum if you can. The decision, usually we have a meeting and to decide what kind of biotherapy we are going to use. We have a problem because we don't have any face-to-face study to know. I told you, I have the impression that dupilumab is better, but of course, there is no face-to-face study. But when the decision is made, the evaluation at 4 months, and to be very clear about the target defined in the introduction. Thank you very much.